Welcome to our deep dive into Bulgaria and colleagues' 2019 Psychot-TJ paper, proposing a new radiological classification system for Hafez fractures.
It's specifically for orthopedic surgeons,
That's right.
like yourself.
We're going to unpack this CT-based system
All right.
and see how it can improve the diagnosis and treatment of these often subtle and complex injuries.
So Hafez fractures, coronal fractures of the distal femur, they represent about 0.65% of all femur fractures.
And as you know, these fractures can be notoriously tricky to spot on plain radiographs. That's where the importance of CT scans comes in.
Exactly. Bulgaria et al. Really emphasized the crucial role of CT imaging in their study. They found that CT scans were far more sensitive in detecting and accurately characterizing Hafez fractures compared to X-rays.
Now, the existing classification systems for Hafez fractures, such as the AOOTA and Letnier systems, haven't been ideal. They don't always guide us towards the most appropriate surgical approach.
That's a key point. The authors of this paper recognized the limitations of these existing systems and sought to develop a classification system that more effectively correlates with treatment strategies.
So tell me what makes this new classification system stand out.
Well, it's based on 4 main types, with type 4 having 4 subtypes. And the key differentiator, fragment size.
Interesting. Walk us through the types.
Type 1 involves a fragment larger than 2.5 centimeters. Type 2 is characterized by a fragment smaller than 2.5 centimeters.
Now, why is that 2.5 centimeter distinction so crucial?
The authors linked this measurement to the grip strength of a 16-millimeter screw, which is commonly used for fixation in these fractures. A fragment larger than 2.5 centimeters provides sufficient purchase for optimal compression and stability.
That makes sense. So how do those fragment sizes dictate the surgical approach?
For type 1 with its larger fragment, anterior to posterior lag screws are recommended. For type 2 with the smaller fragment, posterior to anterior lag screws are preferred to achieve adequate compression.
And what about the other types?
Type 3 represents a comminuted fracture. This pattern often necessitates buttress plate augmentation to ensure stability.
So far, this system seems very practical and user-friendly. It clearly links the fracture morphology to the recommended fixation technique.
You're right. The authors really aimed for simplicity and clarity. But of course, things can get a bit more nuanced.
Let's talk about those nuances. What does type 4 encompass?
Type 4 includes several unique subtypes. We have type 4A, an anterior lip Hafez fracture, then 4B, a bicondylar Hafez fracture. We also see type 4C, which is a marginal osteochondral Hafez fracture.
So a wide range of presentations fall under type 4. That must make treatment selection a bit more challenging.
Indeed, type 4 fractures can require various techniques from lag screws and headless screws to locking plates. The specific subtype and the associated fracture pattern will guide the surgeon towards the most appropriate approach.
And finally, there's type 4D.
Yes. That's the Hafez fracture with a concomitant supracondylar fracture of the distal femur. Those cases, as you can imagine, require a modified approach.
More complex, for sure. But even with these subtypes, having a clear classification system like this can bring much-needed consistency to our approach to Hafez fractures.
Precisely. It helps standardize communication among surgeons and facilitates better decision-making regarding surgical techniques.
Speaking of consistency, how did the authors go about validating the reliability of this classification system?
They conducted a retrospective analysis of 30 cases, combined with a thorough review of 77 studies encompassing 412 cases in total.
Quite an extensive data set. What did their analysis reveal about the reliability of this new system?
They found both high inter-observer and intra-observer reliability.
Now that's reassuring. It means that regardless of the surgeon or the timing of the evaluation, the same fracture would be classified consistently.
Exactly. And that level of consistency is paramount, especially when dealing with complex fractures like these. It ensures that we're all on the same page when it comes to diagnosis and treatment planning.
Absolutely. It can bridge those knowledge gaps and help bring everyone up to speed quickly.
Precisely. Now, while this system offers a robust framework for understanding and classifying Hafez fractures, it also has implications that extend beyond just the operating room.
Let's talk about that. How does this classification system potentially impact patient care?
Well, first and foremost, it aids in more accurate diagnosis. Remember we discussed how CT scans are crucial for picking up these fractures that plain radiographs might miss?
Right.
This in turn leads to earlier intervention.
Early diagnosis and treatment are always paramount in orthopedics. It can make a significant difference in patient outcomes.
Exactly, and with this classification system guiding our treatment selection, we can tailor our surgical approaches and fixation techniques more precisely to each fracture pattern.
That precision is key, isn't it?
Yeah.
It can lead to better anatomical reduction, more stable fixation, and ultimately a better prognosis for the patient.
Precisely. By aligning the treatment strategy with the specific fracture morphology, we increase the chances of achieving optimal healing and functional recovery.
Now, the authors did acknowledge that their study was retrospective and didn't include long-term follow-up. Did they address the potential limitations of their findings?
They did. They acknowledged that further research, particularly prospective studies with longer follow-up periods, is needed to definitively validate the impact of this classification system on patient outcomes.
So it's an exciting starting point that paves the way for further investigation.
Absolutely. This study opens up a new avenue for research, allowing us to explore how this classification can refine our surgical decision-making and ultimately improve patient care.
It's always fascinating to see how research like this can shape our understanding and management of complex injuries. But let's shift our focus back to the practical aspects for a moment. Some of our listeners might be wondering, how easy is it to actually apply this new classification system in a clinical setting?
That's a great question. The beauty of this system lies in its simplicity and practicality. It's designed to be user-friendly, even for surgeons who might not specialize in knee trauma.
So it's accessible to a wide range of orthopedic surgeons.
Exactly. And remember that high inter-observer and intra-observer reliability we discussed earlier? This consistency means that different surgeons, regardless of their experience level, should arrive at the same classification for a given fracture.
That shared understanding is so important for communication and collaboration, isn't it?
It's essential. It streamlines discussions among surgeons, facilitates surgical planning, and ensures a more standardized approach to treating these challenging fractures.
Now, earlier you mentioned that type 4D, the Hoffice fracture combined with a supracondylar fracture, presents a unique set of challenges. Let's delve a bit deeper into that. What are the key considerations when managing these combined injuries?
You're right, those cases warrant special attention. The presence of both a coronal fracture and a supracondylar fracture significantly increases the complexity.
What are the implications for surgical management?
Well, firstly, the fixation needs to address both fracture components. The authors recommend opting for longer, more rigid fixation constructs, often involving locking plates in conjunction with lag screws.
Okay.
This robust fixation is crucial to counter the deforming forces acting on both the coronal and sagittal planes.
So a more comprehensive and robust approach is required.
Exactly, and the surgical approach itself might need to be adjusted. In these combined injuries, approaches like the swashbuckler or subvastus approaches gain prominence.
Can you elaborate on why those approaches are preferred in these cases?
Certainly. Both the swashbuckler and subvastus approaches provide enhanced exposure to the posterior aspect of the distal femur.
Which is where both the Hoffice fracture and the supracondylar fracture components are located.
Precisely. This improved visualization allows for more meticulous reduction and fixation of both fracture lines.
It's fascinating how the surgical approach needs to adapt to the specific fracture pattern.
Absolutely. And that underscores the importance of this classification system. It guides us towards not only the appropriate fixation, but also the most suitable surgical approach for each unique fracture presentation.
It's like having a roadmap that leads us towards a more informed and effective surgical strategy.
A very apt analogy. This classification system empowers us to approach these complex injuries with greater precision and confidence.
Now, before we conclude our deep dive, there's one final point I'd like to touch upon. The authors briefly mentioned the potential long-term sequelae of Hoffice fractures, even with appropriate surgical management.
That's an important point to consider. While our primary focus is on achieving anatomical reduction and stable fixation, we can't overlook the potential for long-term complications.
What are some of those potential long-term issues that surgeons should be aware of?
Even with meticulous surgical technique, patients can experience limitations in their range of motion, persistent pain, or even the development of post-traumatic arthritis down the line.
So it's not just about addressing the fracture itself, but also about managing patient expectations and providing long-term follow-up care.
Precisely. We need to educate our patients about the potential for these long-term sequelae and ensure they receive appropriate rehabilitation and ongoing monitoring.
This deep dive has been incredibly informative. We've covered a lot of ground, from the nuances of the classification system itself to its practical implications for surgical management and patient care. As we wrap up this deep dive, what's one key thought you would like our listeners to take away from this discussion on Hoffa's fractures and this new classification system?
I think it boils down to this. Hoffa's fractures demand our attention. They can be subtle on imaging and easily missed if we're not actively looking for them. This new classification system, combined with the emphasis on CT imaging, provides us with a more refined framework for diagnosing and managing these complex injuries.
So it's a call to heighten our awareness and refine our approach.
Exactly. For those listening, I'd pose this question. How might this new classification system, with its emphasis on CT imaging, impact your approach to evaluating potential knee injuries? Could it lead to earlier diagnoses, more accurate classifications, and ultimately better outcomes for your patients?
Those are powerful questions that every orthopedic surgeon should consider.
I agree. And remember, this classification system is a tool. It complements, not replaces, our clinical judgment and expertise. It's about integrating this knowledge into our practice, continuing to learn, and always striving to deliver the best possible care to our patients.
Well said. This deep dive has been incredibly enlightening. Thank you for sharing your expertise and insights with us today.
It's been my pleasure. Always a privilege to discuss these fascinating topics with you.